Welcome to Afaxys Candid Conversations in Public Health, a new podcast series from Afaxys, a public benefit corporation serving public health clinicians and their patients. Join us as we head to the front lines of sexual and reproductive health care, bringing you timely discussions with leading experts who are shaping the future of public health.
Good morning and welcome to Candid Conversations in Public Health, an Afaxys-sponsored program developed to bring together leading experts in the field of sexual and reproductive health to discuss relevant topics of importance to the public health community. Our topic for today, which is the third in our series of 10 podcasts, is on the front lines of STD prevention, recent advances in HIV, and bacterial vaginosis prevention. This will really be a terrific opportunity to learn from our experts, and there will be some interesting discussions specific to new data in the arena and how this data might translate into or inform ongoing clinical treatment algorithms. I'm Beth Atias, and I will be moderating today's conversation, which I know is going to be robust and dynamic. I'm joined today, as always, by Dr. Kristen Feldman, who's Vice President of Medical Affairs at Afaxys. And our expert guests are Dr. Christina Muzny, MD, MSPH, Professor in the Division of Infectious Diseases at UAB, and a teaching faculty for the Southeast STD HIV Prevention Training Center, as well as an associate scientist for the UAB Center for AIDS Research. Also joined by Dr. Olivia Van Gerwen, MD, MP, Assistant Professor, Division of Infectious Disease, also at UAB, again, a teaching faculty for the Southeast STD HIV Prevention Training Center, and Associate Scientist for the UAB Center for AIDS Research. We are absolutely delighted to have both of you join us today, and thank you so very much in advance for sharing your expert insights and perspectives. So Drs. Van Gerwen and Muzny, could we begin with each of you sharing your background, your journey into your role, and the work which you are engaged in currently and excited about? And would you also please provide any relevant disclosures? And Dr. Van Gerwen, would you like to go first?
Sure. I'm Olivia Van Gerwen. I go by Libby, and I am, as you said, an assistant professor of infectious diseases at the University of Alabama at Birmingham, where I'm a clinician scientist. I do clinical work in the space of HIV prevention, sexual health, vaginitis, gender health care, you name it. I probably do it if it's under the sexual health umbrella. I'm also, as I mentioned, a scientist or researcher, and my research focuses around these clinical spaces. I currently have funding from the NIH to do work about sexual health, specifically the vaginal health of populations at risk for STIs. And then I also do work with Gilead. That's one of my disclosures as a site PI for the Purpose 2 and Purpose 365 trials about HIV prevention. And I enjoy medical education, teaching community and learners in the medical infrastructure of medical school, fellowship, all those things in all of these topics. Additional disclosures, as I mentioned, I have some NIH funding and some industry funding from Gilead. I also have served as a consultant for Biomuru and GSK and Abbott. I've received consulting fees for them, but none of that work is relevant to this discussion today.
Great. Thank you so much. That's a fabulous background. And Dr. Muzny, would you also likewise do the same for an introduction?
Sure. Hi, everyone. I'm Christina Muzny. I'm a professor of medicine in the Division of Infectious Disease at UAB. I've currently worked at UAB for the past 15 years, and my expertise is particularly in vaginal infections in women, particularly trichomoniasis and bacterial vaginosis. So I do a lot of research on pathogenesis, epidemiology, diagnosis, and treatment of these infections. I also do research on vulnerable populations who are at risk for STI, similar to what Libby mentioned. And I currently have several NIH-funded grants. Part of my disclosures, a BV pathogenesis study, as well as a clinical trial for the optimal treatment of trichomoniasis in women and men. In addition to my research, I'm also chair of the UAB Institutional Review Board, where I review a lot of protocols around the UAB campus and help investigators with their work. In addition, I'm medical director of the UAB ID Vaginitis Clinic and the UAB Sexual Health Research Clinic. And my disclosure, so I have funding from several industry companies for studies, including Gilead that Libby mentioned, also BioNTech and Abbott. So thank you so much for having me and looking forward to discussion.
Really fantastic. What a dynamic duo. I don't know when you have time to sleep, either one of you. Really,
Sleep is a priority. Sleep is a priority.
very good. Great. Well, thank you. And Dr. Kristen Feldman, would you also please introduce yourself and share a little bit about Afaxys for our listeners who might not be familiar with the work that you do?
Sure. Thank you, Beth. I am the Vice President of Medical Affairs at Afaxys. I'm also a practicing gynecologist in North Carolina. Afaxys is a public benefit corporation serving the needs of public healthcare clinicians and their patients, specifically in the area of sexual and reproductive health. We have a drug development arm, a pharmaceutical arm with a portfolio of generic, oral, and emergency contraceptives. And we also have a group purchasing organization, which allows smaller clinics to have more purchasing power for the myriad of supplies and services that they use every day.
Great. Thank you so much. As I mentioned, and as you know, today we'd like to talk about recent advances in HIV prevention and treatment, in addition to advances in these domains for bacterial vaginosis. So, Dr. Van Gerwen, since obviously you have a great focus within infectious disease in the HIV arena, could you share with our listeners the evolution from your perspective with regards to prevention in this arena?
Sure. So HIV prevention is relatively new, though it's feeling less new every day. I first learned about it when I was in medical school when they were developing HIV prevention in the biomedical sense with pills that could be taken to prevent HIV. That was in 2012, and it was just coming out. The first HIV prevention medications that were available were daily oral pills. The first one was brand name Truvada, but the generic is tenofovir, disoproxil fumarate, and trazodone. And these are pills that are taken once a day for prevention of HIV in populations who may be at risk of contracting the infection. So this was a huge game changer in the space. It had a large impact on a lot of communities in helping them feel more sexually free, helping them have more fulfilling sex lives. And it was also a really big game changer in terms of quelling the epidemic that we're seeing with HIV. So that was the first. They quickly followed Truvada with what's called Descovy. Again, that's the trade name. It's essentially the same medication, but formulated a bit differently. It's tenofovir alafenamide, disoproxil fumarate, again, a daily oral pill. So for a while, we've had oral pills as the option for populations that we see. But in the last 4 or 5 years, we've begun this new frontier of injectable drugs to prevent HIV. The first being cabotegravir. The brand name is Apretude. So this is an intramuscular injection that's given every 2 months to prevent HIV. And most recently, which we can talk about in a minute, a new subcutaneous injectable that can be given every 6 months, lenacapavir, was FDA approved in, I believe, June for HIV prevention. So these medications are all used, as I mentioned, just to prevent HIV. They don't prevent other STIs, pregnancy, anything like that, but they are extremely impactful. And now that we have options for patients who have different needs, for example, people who aren't able to take pills every day now have long-acting injectable options, and people who don't like needles can also still take oral pills. I think the landscape is really becoming diverse and patient-centered, which is excellent. There are options for all types of people as well. Women, people assigned female at birth, men, people assigned male at birth of all gender identities can take most of these things, the exception being Descovy, which is not approved to people assigned female sex at birth. Those are the options, and there's always a lot going on in the development of how we get these drugs to people, how we implement these services into public health spaces. I think those are some of the new frontiers, how we improve uptake of these medications. And also for the pills in particular, novel dosing strategies have been explored recently as well. For example, you can do intermittent dosing of the 2 pill options of the medication for some populations, meaning you can have patients take it around the time of sexual activity, before and after, instead of having to take it every day. But these are all kind of new frontiers for the field, and I'm excited to see where it goes.
Great. Thank you so much. It really is a tremendous, evolution and really a public health victory. And now, as you mentioned, to be able to provide a customized HIV prevention for patients. So I'm glad you pointed out some of the barriers, and we'll talk more about that later. But I did want to ask you, because we understand that you were the UAB site principal investigator for the Purpose 2 trial, which studied the efficacy and safety, as you were mentioning, of the long-acting injectable antiretroviral lenacapavir. I'm sure our listeners would love to learn more about this trial, its genesis, and ultimately the outcome.
Yeah. So this was a trial it's part of a family of trials, all sponsored by Gilead, as I mentioned. So Purpose 1, I'll talk about that a little bit first, was the first study. It was looking at lenacapavir, which is a novel mechanism. It's a capsid inhibitor, so it works differently than the other antiretroviral preventive agents we have. And it can be injected and has a very long half-life. So in Purpose 1, they looked at how well this medicine worked and how safe this medicine was in a population of women in Africa, so adolescent and young women in Uganda and South Africa. It was done and was looked at in comparison to the oral medications that I mentioned. So they didn't do a placebo-controlled trial for ethical reasons, obviously, right? We have a very effective HIV prevention medication on the market. So they compared lenacapavir to the oral medication that I mentioned, intracytidine, tenofovir, alafenamide, and they then found that essentially in the group of adolescent girls and women who were in the lenacapavir arm, none of them acquired HIV. So it's very rare that we see a zero in these kinds of trials. So the efficacy was outstanding. They actually stopped the trial early because the efficacy was so profound. It was also quite safe. And so that was really huge. It was published in the New England Journal, but that was the study in women. The study that was done, and so again, sorry, I'm going to clarify, they compared lenacapavir to both of the oral medications that are available. So it was compared to Truvada and Descovy. But again, the lenacapavir was very effective. So Purpose 2, which was a sister trial of Purpose 1, looked at the same outcomes and the same medications. They compared the Truvada medication to the lenacapavir medication in men and gender diverse populations. So this was the study we were a part of. It was done in the US and a few international sites, Brazil and Thailand and a couple of other places. So they enrolled folks compared to an active control of the Truvada. And again, they found extremely high efficacy of the lenacapavir in preventing HIV infection. There were only 2 infections in the cohort of over 3,000 people. There's ongoing discussion about what those 2 cases looked like and why that happened. But again, it's extremely promising that so many folks were able to come out of this trial without acquiring HIV, demonstrating the efficacy of this medication. Also, the trial was stopped early because of such profoundly impactful results. So both of these trials led to the FDA approval of lenacapavir for HIV prevention in all populations. This was back in June. So this is now an FDA-approved medication for prevention. And we're actually seeing a lot of places roll it out to patients, and insurance is covering it for a lot of these patients, which is excellent because, as you can imagine, it is not a cheap medication, as a long-acting injectable rarely is for any medical condition. But I was speaking to our HIV prevention clinic director at UAB the other day, and he said they've already dosed 10 people with lenacapavir in our clinic here, and then we're working to transition our trial participants from the UAB site into care as well to continue the medication if they wish to.
Thank you so much. Really exciting and compelling data. And I know our audience is happy to hear from, one of the PIs within the United States. So thank you for that. And thank you for sharing the show notes, which will be available to our listeners. So you had mentioned patient experience, and wondering, what has been your experience to date regarding patient receptivity and barriers to prevention, if any, and any programs that you might be employing that you could share with our audience, some examples.
Yeah, so the place where I prescribe PrEP is actually in my gender health clinic, which is not within our kind of Ryan White funded HIV clinic where our big UAB PrEP clinic is. And I think the biggest barrier I've had with talking about these medications with those patients is some of the logistics of doing a long acting injectable in a clinic setting that isn't set up for that explicit purpose can be challenging. For example, how you get it paid for is a bit complex. So I think that is something that a lot of clinics are still trying to work out. But places like our PrEP clinic, which is a different, like I said, it's an extension of our HIV clinic where we do HIV treatment, they have worked out a lot of systems to help with getting insurance to cover this medication, to work on payment, to work on access that was informed by their experience with Apretude, which was the first long-acting injectable that's given every 2 months. So they kind of learned a lot of lessons in that on a larger scale, able to implement it. So I think it's a challenge in terms of where your practice setting is, getting the logistics down. So that's more of a provider challenge. As far as the patients go, patients are coming in asking for, long-acting injectables, both in HIV treatment, because we do use some of these drugs in combination with other drugs as treatment as well. So patients are asking for it in treatment. Christina, who's on the call as well, is also an HIV provider. I know that her patients probably are similar in requesting the treatment drugs, but in the PrEP space, it's also true. So patients want these things. However, there are a lot of patients who still want to take a pill every day. So I think it's more about having options. Like I think the portfolio of injectables, pills, whatever's on the horizon in the future, it's just like anything else. People want to have something that fits into their daily lives. And the people who don't like the injections, generally it's because they find it easier to remember to take a pill every day than to remember to come in, every so often to get an injection, for example. Or they may not like the injection site reaction that they experience. That's probably the number one thing that people don't like about the injections, but most people are willing to live with it because it is such a convenience. So the most common effect, the adverse effect that people noted in both Purpose 1 and Purpose 2 trial were injection site reaction. It's a subcutaneous injection that's meant to last 6 months. So, you can imagine it forms a depot under the skin, kind of like Depo-Provera or, some of the antipsychotics we use in long-acting medications. And it slowly elutes over time. So there's a nodule for some patients, especially people with a smaller body habitus. It's generally not painful, but some people don't like it. And so that I think is the number one thing that people say, this may not be for me. But again, I think it's a wonderful option for a lot of patients.
Great, thank you. I mean, how tremendous that there are so many options today for patients to choose from. Dr. Feldman, from your perspective, to what extent have the customers which Afaxys serves in the public health setting expressed interest in these longer acting HIV injectable formulations or other treatments and kind of your experience with that public health customer base?
Sure. At this point, based on what our customers are buying through the group purchasing organization, oral PrEP does still seem to be the dominant regimen. I think it's important to remember that the wheels of medicine turn very slowly. And the injectable PrEP options are relatively new, right? Especially lenacapavir, just being approved this summer for PrEP. And, with any new drugs, there's always going to be the questions that Libby mentioned: cost, access, clinic workflow, all of those come into play. But as you both mentioned, I think the strength of HIV prevention now is having different options for different patients, right? Because different patients value different things. So I'm excited that we have these new options to offer to patients.
Terrific. Thank you. Yes, because it's terrific that not only are you VP of Medical Affairs of Afaxys, but you also have maintained your part-time, your clinical GYN practice. So it's always terrific to hear your perspective.
Rick, I'm so sorry. I did want to mention one thing that I forgot to mention that's important for this audience. And just you were talking about Dr. Feldman's practice. These are medications. The Purpose 1 trial in particular didn't enroll pregnant women, but they did allow them, if they became pregnant, to stay in the trial. And so there is ongoing efforts to include pregnant women in this type of work to be able to get these medications to patients. So at this time, I don't believe it's FDA approved to give to women. I would have to double check that because I don't take care of pregnant women. But all that to say, pregnant women were, included in this trial, which I think is really important. Truvada is something that is approved to give in pregnant women, actually. So oral PrEP is available to women who are pregnant, which I think is an excellent, especially on the global health stage, an excellent thing to point out.
Great. Thank you. Thank you for mentioning that. Before we switch gears to bacterial vaginosis, Dr. Muzny, any comments or perspective that you'd like to add with respect to the HIV kind of evolution and arena before we move over with a focus specifically for you in the BV arena?
Yeah, I think the biggest take home is pretty much what's already been said. I think our patients value different things, and we are having more and more options now for things that they can choose from to take in their efforts to prevent HIV. And so I think it's just really exciting that the pipeline of drugs is expanding. And so we can hopefully move forward and hopefully see more patients get on some of these long-acting injectable agents in the future.
Thanks for listening to Afaxys Candid Conversations in Public Health. To learn more about our mission and resources for clinicians, visit afaxys.com. Don't forget to follow or subscribe so you never miss an episode, and we'll see you next time.